Okay, this is Debbie Lee, and I'm going to be talking with you about burns. And we'll as so this is an appropriate time to start talking about burns because this is the time of year when people start using space heaters and have fireplace going and that sort of thing. So we'll see a lot of house fires and with injuries, unfortunately. So what happens with a burn is that we have some injury to tissue, and it's caused usually by heat or chemicals, electrical current, radiation, smoke inhalation, that kind of thing. And there's several phases. There's the pre-hospital. That's, of course, from the time of the incident until they stop the burning phase and the process. And we've got to protect not only the patient, but if we are the first responders or the ones caught up in this fire or whatever with the individuals, we have to protect ourselves as well because we don't want to become part of the incident. Electrical injuries, certainly we have to remove the patient from the source of the electricity if it hasn't already moved on. Chemical injuries, we might brush solid particles away from their skin. Some chemicals you can lavage with water. Some certainly you cannot. Small thermal burns, we're going to probably clean those and put cool tap water or dampened cloth on them. Large burns, thermal burns, we're going to be watching for airway and breathing and circulation. With large burns, this is pre-hospital. We are not going to take time and immerse someone in cool water at their home or pack them in ice or anything like that. We're going to wrap them in clean, dry sheets or blankets or even maybe even newspapers, because newspapers that are fresh off the print are pretty clean utensils to use. We're going to talk about the different phases, the emergent phase. So we're just going to jump right in. And these are also some of the topics we'll be discussing. The pre-hospital, emergent, acute, and rehab. Of course, the pre-hospital, you understand that. The emergent is also called the resuscitative or hypovolemic phase. So as you can imagine, that's kind of descriptive, isn't it? We're going to be resuscitating these patients in some manner. It may not be that they're not breathing or have a heartbeat, but we're doing a whole lot of measures. It's kind of like doing a code on someone. And that's certainly why they call it hypovolemic, because we'll talk about the fluid loss that these patients sustain. And then the acute phase, the emergent's usually about 24 to 48 hours. The acute is then the time when the patient has a diuretic phase. So the emergent is hypovolemic, as you can imagine. Urine output's going to be down. The acute is when they start to diurese. So, and then the rehab is until the time that all their burns are covered with some kind of skin. And we'll talk about the types of burns and care. So we'll get on with it. So when we're looking at what happens with the burn, we know that burn isn't just all local. It's not just if it's your arm. Certainly it can affect systemically as well. We have protein loss, fluid loss. Certainly sepsis is a big problem. So most body systems are affected. So, and even after healing, there can be complications such as contractures. So we're going to be looking at all the whole spectrum of burn care. And of course, there can also be disability, dysfunction, or death from burn injuries. Remember that our skin is our largest organ that we have. There's the epidermis, and that's the outer layer, and it can grow back after a burn because it's got the hair, it's got the oil, sweat glands, and everything. And let's see what else we got here. The dermis then has all these other things in it: collagen, connective tissue, blood vessels. So you can see that's a lot deeper, and we start getting into some some problems. So the epidermis is the outer layer. It can grow back after a burn, but the dermis, some of it, we may have some problems with that. So what our skin, how important is it? Well, as you can recognize, it's a protective barrier, so it helps us to maintain fluid and electrolytes. Massive fluids can be lost after a burn. Injured skin loses fluid through evaporation 4 times faster than uninjured skin. Of course, microorganisms can get in, so we certainly have a risk for infection. If sweat glands are injured or destroyed, then they can't excrete, and burns are very painful. You remember your skin has all these sense organs for pain, pressure, temp, and touch. So with a partial thickness, the nerve endings are very exposed and it's extremely painful. Now with a full thickness burn, which is much deeper, then we have the endings, the nerve endings are destroyed. So, and we'll talk about that a little more. Now some other things that our skin helps to do, we have sunlight that reaches our skin and activates vitamin D. And remember, we have to be able to, we absorb that from our calcium and our phosphorus that's in our GI tract. So you can see how now it's starting to affect all areas, all systems. Maybe just your legs are burnt, but you can see how just that amount can alter our circulation, our vitamin D, our GI tract, all of it comes into play. And certainly, much of our own personal identity relies on our personal appearance. So, if your face gets burned or what have you, that can be a major psychological problem. And normally, there's also a small range that our temperature, our body, withholds. So, we might be okay at 104. But then we can get trouble set in. You know, if we've got a temp of 104, that's really a lot. Maybe not for a child to run for a short period of time, but for adults in particular, we've just got a small margin of error to work with. Okay. So looking at classifying burns, we certainly know that the severity is determined by a lot of factors. And the American Burn Association advocates using different terminology, using partial thickness and full thickness, because they're much more descriptive terms. We used to use first degree, second degree, third degree, and fourth degree, and those are just really not quite as descriptive. So now we're using partial thickness, full thickness, superficial, meaning it just involves the epidermis, and then deep partial thickness involves the dermis, and then full thickness involves muscle, fat, and bone. So we know that severity is by the depth and by the extent. How much, if it's just one arm that's involved, that's certainly as bad, especially if it's your arm. But if both arms and a leg, that's certainly a greater concern. And of course the location. Is it your face that's burned? Are your hands burned? You can see where having your both hands burned would mean that maybe you are unable to do activities of daily living, so you might have to have a lot more help getting bathed, getting fed. You might not be able to work the keyboard. Oh my goodness, we'd probably all die if we couldn't use our telephones. And the location, certainly other locations like your perineum, if that's burned. For several reasons, that's very painful. It may interfere with using the bathroom. It may interfere with sex. And also it's a dark, warm, damp place, so bacteria, we can have a real high incidence of bacterial growth in the private areas. And other risk factors also would be, do you have other problems going on? Do you have other comorbid things? Are you elderly, or are you a youth? We know things really affect the elderly and youths, especially children, infants, much quicker than they do strapping healthy folks. Do you have diabetes, hypertension? Are there other problems going on. So all those risk factors will play into it. Looking at this cross section shows here's the muscle down at the bottom, bone, and then covered by muscle and fat with all these things that are in the dermis area, our hair follicles, sweat glands, and what have you. And then you see the outer layer is just really quite thin. And yes, we can have just this epidermis affected, epidermis, I can't want to say dermis, affected, and we can also have then this whole area, epidermis and dermis affected, and then we can get on down into involving the bone and the fat and the muscle. And you can imagine when those are involved, full thickness, and you see here this is superficial, deep, partial, and then full thickness. And certainly with the full thickness, we're going to have more complications and longer lasting complications. Okay. So we're still looking at that, what we used to call first degree. That's where we have very much superficial. That's for minor little scalds and what have you. And sunburn. And it's very, very painful, but it usually heals up in a few days. We're not going to spend much time on that because it's just not necessary. Partial thickness, though, what we used to call second degree. You can see superficial. That's the epidermis only. Then it can get a little more. Also, I'm sorry, I meant to tell you this. The first degree can also. This says second degree, but partial thickness can also blister up and peel the next day. So usually with the totally superficial, we don't have any blistering. However, this can, and if you've ever had a sunburn, it's like flat and just sore today, and then tomorrow night you get these blisters, and so that's what we're talking about. So it can blister and peel. Now here's a partial thickness on some little child's legs, and you can tell they've been immersed in hot water, and you can see the line of demarcation here, where they've maybe been made to stand in hot water. I think we should find who did it and let them stand in some boiling water, maybe. Just teasing. Okay. And here is a client, a dark-skinned client that had partial thickness burn to the hand. Let's see if all burn off here. And this was a full thickness, so we went on down and got some of the fat, maybe even some muscle on this, and now it's healing up though. But you can see how it left kind of a hole, and it looks like that maybe they closed it up, maybe with a skin graft or something. Because a full thickness, which is the old 3rd and 4th degree burns, do require skin grafts. And you can see it can be a wide range of colors. It can be charred dark, it can be dark tan, red, black, or even charred to where it's like a white color. So, and the bad part about partial thickness or deep partial thickness is that with a little time, they can even turn into full thickness because of the decrease in the blood flow, increase in edema, that sort of thing. So, you know how in neuro we said we couldn't tell how bad their injuries were going to be until the swelling went down? Well, that's a lot of how it is with the burns as well. And if a large area is involved, then we might have lesser burns of the head and neck and deeper burns of the trunk or legs or whatever. So, now another thing we have to consider is if the burn goes all the way around the limb or the trunk or whatever, because circumferential burns can cause some compromise to blood flow. I mean, any of them can, but certainly it's like if you put on a tight bandage, it might be tight, but if you put a bandage on that goes all the way around the limb too tight, then we might get sort of like a compartment syndrome. So we have to really look at that. So we look at especially face and neck and chest to see if there's any respiratory obstruction or anything. And then also the hands and feet and joints and the face and all. Are we going to be able to perform self-care? And also the nose and the ears. Very easy for these places to get infections. And they have such good blood supply as well. Okay, so we're looking at some of the different things that happen when we get a burn. We have some vascular changes, and that's one of the big boogaloos that happens when we get a major burn. And I'm not talking just your finger burn or your hand burn. I'm talking like if you get 25% or 30% of your body burned, or your client gets 25 to 30% of their body burned. Usually that is enough to send them to a burn unit for specialized care. And what we see is this third shift, the fluid shift called third spacing. In the first phase, or the emergent phase of a burn, which remember I said takes about 24 to 48 hours, what we want to make sure is they have an airway. We want to make sure we're replacing their fluids. We want to prevent infection, maintain their body temperature, and certainly provide emotional support for them and for their families. In electrolytes and fluid and electrolytes, we're going to see shifts. So the capillaries are damaged or destroyed, so they leak, and we have a colloidal osmotic pressure decreases, so it results in more fluids shifting out of the vascular space where it usually is and out into the interstitial spaces. And so the net result of the fluid loss is that we get a depletion of the intravascular space. So we have edema out in the tissue, we have a lower blood pressure because the venous loss into those tissues, and so the blood pressure is down and the pulse is up, both trying to maintain homeostasis. So we have fluid and electrolyte shifts. We lose sodium and potassium. And we see all this is starting first little bit. They get puffed up pretty quick, so we can get we lose sodium, and patients are going to possibly get an increase in their potassium. Did I say decrease in sodium? I think I still tried to say that wrong. And an increase in their potassium because of all of the cell damage to the tissue, the area that is burned, because of all the RBCs that are out there in little tiny capillaries and in blood vessels and what have you. So that the potassium gets injured and some of it gets reabsorbed into the bloodstream and all. So it's really can cause some problems. So what we'll see is the patient may look hemoconcentrated. Their results may look okay, but they're really hemoconcentrated. So their hemoglobin and hematocrit may actually be low. So after this initial stage, this hypovolemic or emergent phase goes on, or resuscitative phase, those first 1 to 2 days, then we're going to see the fluid out there in the tissues start to kind of goes, okay, let's go back in. The crisis is over, now let's go back in. So what we'll see is all this fluid will rush back into the vascular spaces, and we will get a big diuresis. So, and when that happens, then we're looking to see if we lose potassium. So during the first phase, that emergent phase, we will not be giving the patient potassium. That would be a warning because their sodium's going to be low, potassium potentially high. But in the remobilization or the acute phase, after that first emergent phase, we get to the acute phase when they diurese, and we'll probably lose potassium, so we'll have to be watching for that. In both phases, we're going to be watching for both, for the electrolytes. Okay. And these are some other, talked about the vascular changes, and certainly our cardiac. That's why I was telling you, all systems kind of get affected by a major burn, a burn that encompasses 25 to 30% of the body. And so you see pulmonary things start to change. The inflammatory compensation starts because that's part of in the immunologic phase. That's part of healing, is when that immune response kicks in and starts to fight infection and all. Your body just starts doing these things on its own. Sympathetic nervous system compensation starts to occur when there's any stressor is present. So all of these systems are going to get kind of tweaked a little bit. Now, certainly looking at older adults, like I said, and the young, they heal slower and have pre-existing problems like other comorbidities and what have you. And then some other things that can happen are if patients are alcoholics or have drug abuse problems or are already malnourished. So you can imagine how problematic that can be for someone with burns. And then, of course, also, just because they've got burns doesn't mean they haven't gotten some fractures or lost some limbs or had a head injury or other trauma along with the burn injury, so which would certainly complicate things. Different types of burns, just to name a few, certainly. Thermal is can be dry heat or moist heat. Contact burns can be by a flame, flash, scald, or contact with a hot object. And it's the most common type of burn that we see. And remember, after 24 hours, they can blister and peel. Sunburn usually falls under the first degree, so we don't mess with it. Superficial is usually epidermis only. Dermis actually is dermis only. Very painful. Chemical burns can result in a lot of very tragic tissue injury and destruction, and very often they are very necrotizing and can just, especially the acids, can cause just liquefaction of tissue. It's very bad. And sometimes it can last. We talked about we need to put the flames out, but on chemical burns, sometimes those burns can last and take 1, 2, or even up to 72 hours to really run their course. So very often we're looking for respiratory problems to come with that, if maybe even a chemical inhalation like chlorine. Let's see. And eye injuries certainly can be pretty traumatic too. Electrical injuries may be sparked by a patient's clothing, that kind of thing. And so they may also have an electrical burn as well as a thermal burn. So it certainly depends on if they were shocked by a falling wire, or if they were doing some electrical work and got, kicked back from that. Depends. Is it 120 to 220, or is it at a power plant or whatever? So it depends on how much current they received, how long they were in contact with it, and also the surface area of how far it went. So we'll talk about that a little bit. Radiation, I'm not really going to talk about that because I know you've talked about it in treatments, as far as like cancer treatments and things like that. And you probably may have talked about it in the emergency treatment as far as like a nuclear event or something. Inhalation injuries, we will see those occasionally. Sometimes it's carbon monoxide poisoning. Sometimes it may just be like we may see a fire, and the patient may not have gotten any fire injuries, but they may have had smoke inhalation, which can certainly kill them just as quickly, and they're just as dead. But we'll talk about that because it's because of all the chemicals, the wood burning, furniture burning, and very often these things, plastic stuff, all give off a lot of toxic gases, and which your body just takes them on real quick, just like the carbon dioxide, and makes it easy, and they don't smell it if they're asleep or if they're knocked out or anything, so it can be really tragic. Cold thermal injury, I'm not talking about that. I think y'all talked about frostbite and all and emergency stuff, so I won't bore you with that. This is a picture of, I think, a gentleman's hand that was holding something, and you can see he took an electrical burn to his hand. His fingers look like they're going to slough off some of the skin there. And the bad part is that it probably went in one place and it came out the back, possibly. I have seen patients come in, they were working on electrical lines or what have you, and they've been blown off of them. And that's another thing with any electrical burns. You have to always look, because of the shock that goes with it. We always do fall precautions and skeletal precautions and all, because they very often can have fractures, either cervical or on down the spine. So we do put them on, boards and carry out spine precautions on them, because we don't know until we x-ray to make sure. But I have seen patients come in that they took a shot to their hands, it went through their heart, caused them to fibrillate, and went on down, and as this current is traveling through their body, it's doing damage to whatever tissue it comes in contact, because it's like, thousands of volts going. It's like lightning going through you. So it's, doing damage to tissue, which includes fat, could be bone, could be blood vessels. And I've seen it come in the hands, defibrillate the heart, go down, go out their shoes, and their boots would be smoking. I mean, literally have burns on their toes, and their boots would be burnt and smoking. So you will see these things happen, and that is like getting a major defibrillation going on, or fibrillation, whichever. So there's two common types of instruments that we use to determine percentage and total body surface areas, and that's the Lund-Browder and the rule of nines. And this is the rule of nines, real easy, down and dirty. The head and neck, 9. Arms, 9 each. Anterior trunk, 18. Posterior trunk, 18. Legs, 18. And the perineum, I'm sorry, I know y'all think that might be more important, but only gets 1%. So that's the head and neck. That's the total of 9. Arms, 9 each, and that's the front and the back both. So if it's, half of the arm, then you'd do 4.5. I mean, just kind of, you can just down and dirty it like that. Anterior trunk, that's like from the whole chest down to the perineum, almost to the perineum, is 18. The back, from all the way shoulders down to your booty, all the way down, taking in your booty, that's posterior trunk, 18. Legs, 18 each. So if it's, half of the leg or the whole front of the leg, but not the back, then you'd count 9. If it was just, the whole front of it. And then the perineum, and that adds up to 100, I believe. Okay? And that's a real quick, down and dirty, and this is not like absolute science, because the thing is, you may, the extent of it is not known yet until all the swelling and damage is done. So it could be more often. This will allow you to really estimate a little over, but hey, hadn't you rather estimated it a little high than to underestimate it? Okay? And here's the Lund-Browder, and you can see it's got a much broken down a lot more. And then there's another one, and I can't think of what the name of it is, but it has also the body weight that goes into it, which certainly you would use for a child getting more. But this is for the down and dirty emergency EMS, the quick look. Okay. And what I'll be holding you responsible for is the rule of nines. So not the Lund-Browder, just the rule of nines. Okay, I will be holding you responsible also for knowing how to figure fluids for a patient. And so I think this shows it pretty well delineated here. If the patient weighs 165 pounds, you convert that into kilograms, which is 75. And let's say he has 30% or she has 30% of their body burned. Well, you just plug those numbers in. The formula is 4 mLs of lactated ringers per kilogram of weight times the total body surface area without the 30. Now, where we've got 30%, you drop the 30 and drop the percent and just say 30. Just put the number in. So here it is, 4 mLs times the 75 kilograms that they weigh times the 30% of the body burn, and that gives you the amount of fluid that they will receive for the first 24 hours after their burn. So that comes out to 9,000 mLs the first 24 hours. Okay? Now, this is a guide. That doesn't mean if your doctor in your ER doesn't do it exactly this way, but this is there's Parkland and there's the Baxter, several formulas. This is a very well accepted one. So, but certainly we have to look at the size of the patient, the burns, other areas. Are they a heart patient? We look at a whole lot of things. But this is a guide to go by, and I will be expecting you to know it. So the first, 24 hours. So of this 9,000 mLs of fluid, the first 8 hours, we're going to give them half of that. So that is 4,500 mLs the first 8 hours. Okay? Then the rest of the fluid we're going to split and give them over the next 8 and the next 8. So the next 16 hours, they're going to get a quarter of this total. So does that make sense? They got 4,500 the first 8, the next 8 2250, and the next 8 2250. All just a guide. Okay? All right. There it is, written down again. Then the second 24 hours, they usually do a half to 2/3 what they did the first day. Okay? And it depends what their vitals are doing, what their mental status is, how are they, do they have pulses, what's their weights, that kind of thing. Main thing we want to do is maintain urine output at 20 to 50, 30 to 50. That's our magic number, isn't it? 30 mLs an hour. This is for an adult. Okay? All right, let's take a break there, and that might be all you want to chew on for a little bit, and we'll come back and start here. Thanks.